Hello there, it's Luke, and in this session, we're going to be thinking about the signs and symptoms and the underlying mechanisms for those that are related to cardiogenic shock. Now, excuse me, there we go. So you recall that we said shock is a failure of blood supply of all the good things that the tissues need, like oxygen and glucose and nutrients, to the tissues, and a failure to remove those toxins and waste products and carbon dioxide and all the rest of it from the blood tissue, from the tissues. And there are four main types. And in this tutorial, we're going to be considering cardiogenic shock. I'm just going to put you at the top of the screen there. So there are many different causes for cardiogenic shock. Ischemic heart disease, so if somebody has an occlusion of one of the coronary arteries and that damages the heart muscle, it's not going to pump as effectively. There's also cardiomyopathies which can be acquired or be genetic. There's inflammation or infection of the heart and the heart muscle, and also valvular heart disease. So we're thinking about things like aortic stenosis and mitral regurgitation, where the valves aren't competent. They're either too stiff or they're floppy and they're letting blood flow backwards through the heart, if you like. And then we may go into a form of cardiogenic shock related to how fast the heart is going. So if it's going very slow or if it's going much too fast, and we refer to those as bradycardia and tachycardia, respectively. So first thing to say that in many of the forms of cardiogenic shock, the chief issue is that a failure of contractility, by which we mean the heart is contracting with less force. And if it's doing that, there's less stroke volume, so there's less blood ejected each time the heart contracts. And so our cardiac output, that's the amount of blood that's ejected over a minute, is down, and consequently our blood pressure may well be down as well. And if you've been doing these tutorials, no doubt seen this slide before, but in the center of your screen, you can see this is the left ventricle. It's beating really well. All the walls are coming together and it's squeezing lots of blood out into the systemic circulation. And in this one on the right, well, we've got this big dilated, tired, failing heart. And clearly the contractility is poor there, and it's not managing to eject a great deal of blood with each contraction. Now, in a failing heart, if we think about the Frank-Starling curve, so this describes a relationship between how full the left ventricle is, and we find that the fuller it gets, actually the myocytes and the heart muscle stretch more, so that when it contracts with more force, kind of like a piece of elastic. However, in a failing heart, we reach a point further along, there's my cursor, where actually the more blood that is returned to the left ventricle, actually we begin to see a deterioration in the force of contraction, and deterioration in the volume of blood that's ejected from the left side of the heart. And this is occurring in the failing heart in cardiogenic shock. Now, you'll remember that we've got various compensatory mechanisms that are aimed at improving the blood pressure and therefore tissue perfusion. We've got a renin, angiotensin, aldosterone system, and our baroreceptor reflex. And both of these in their own ways will cause contraction of the smooth muscle within the blood vessels, with the aim of improving the systemic vascular resistance and improving the blood pressure, but also improving venous return back to the heart. However, this increase in systemic vascular resistance actually will increase what we call afterload. So you'll remember that afterload is that pressure that the left ventricle must overcome when it contracts to open the aortic valve. So this is a pressure coming back from the systemic circulation that the left ventricle must beat against to open the aortic valve and get the blood into the systemic circulation. And this can actually worsen heart failure. And as we just mentioned before, if you've got blood being squeezed away from the peripheries, you increase your venous return, which in general is a good thing unless you've got a failing heart, at which point on our Frank-Starling relationship, we're over here, and actually that extra fluid isn't doing your heart any good, and making it work too hard, and it's overstretched and it's not contracting well. So yeah, in cardiogenic shock, where you've got this sort of failing, weak heart, you've got a problem of contractility in the first instance, but then the compensatory mechanisms that should increase your blood pressure, improve your tissue perfusion, actually means that your heart has to work harder and is too full and overstretched and isn't beating well for that reason. Now, we're going to change a little bit and we're going to start to think about the heart valves. And I'm going to think mainly about the heart valves on the left-hand side of the heart. So I'm going to chop our diagram in half again. So we've just got the left side of the heart. We've got blood flowing back in through the pulmonary veins, into the left atrium, into the left ventricle, through the mitral valve. And during contraction, it's going to squeeze the blood through the aortic valve and into the aorta. Now, there are a couple of types of valve disease that we're going to talk about here, and the first of which is aortic stenosis. So in the diagram at the top, we've got systole occurring, and there's a lot of these purple arrows denote sort of force, if you like, or pressure, and as the myocardium squeezes, it overcomes the afterload pressure going back from the systemic vascular resistance, and so there's greater pressure generated within the left ventricle and the aortic valves opened, and so consequently there's blood flow into the systemic circulation. With aortic stenosis, this valve here is calcified and tight and inflexible. And so not only do you have to overcome the pressure coming back from all the sort of vasoconstriction, if you like, you also have to overcome the pressure and the resistance to flow from this sort of stiff aortic valve. And so the heart muscle has to pump harder to open the aortic valve. And when it does, because it's sort of narrowed and stiff, there's less blood flow out into systemic circulation, and that will impact on tissue perfusion. It's a slightly different story with mitral regurgitation. So mitral regurg is where the valve doesn't close fully and blood can be not only pumped into the aorta, but also, I suppose unintentionally, pumped back into the left atrium. So again, we have our healthy diagrams at the top and at the bottom here. Whilst the forces are the same, so you're still getting some afterload come back, you're getting the same amount of force generated by the myocardium during contraction. However, not only does the aortic valve open when there's enough force, but the mitral valve, because it doesn't close properly, opens as well. So a percentage of your stroke volume is going back into the left atrium. And so we have a decrease in our stroke volume that's entering the systemic circulation. And when we compare those two types of valve trouble side by side, you can see that aortic stenosis has an issue with an increase in afterload because you've got a stiff valve that you've got to try and squeeze the blood flow, and also for that reason, for the same amount of pressure, actually you're not getting as much stroke volume, so you're not getting as much ejected on each contraction. And with mitral regurg or mitral regurgitation, because that valve is incompetent, so it doesn't close properly, there's some blood being ejected into the left atrium as opposed to all the blood being ejected into the aorta. Now, thinking about bradycardias, and we define bradycardia as any sort of 40 beats or less, or 60 beats or less rather, we can see in this sort of really simple illustration here that obviously if your heart is beating less frequently, there's going to be less cardiac output, and there's going to be less chance that your tissues are going to be perfused properly. And we can get bradycardias for reasons to do with sort of ischemia of the sort of areas of the heart that are involved in conduction, and also arrhythmias that may occur. Maybe you get heart block, and some drugs such as digoxin can cause a very slow heart rate that actually leads to a cardiogenic shock. Conversely, we have here a ECG rhythm strip showing a tachycardia. Now, you will no doubt recall from your cardiac physiology that the heart refills, and the left ventricle in particular refills when it's relaxed in diastole. Now, if your heart is beating that much faster, there's less time for the left ventricle chamber to refill. And so actually, as your heart beats faster, your left ventricle doesn't get as full, your preload drops, and so your stroke volume will drop because there's less in the left ventricle to get pumped out. Consequently, your cardiac output is low and your blood pressure will be low because of that. And again, comparing those two side by side, you can see that in bradycardia, the height rate is too slow. You're losing that cardiac output, if you like, around the stroke volume. And with a tachycardia, because the heart never refills properly, never gets the adequate preload, you get a drop off in stroke volume there as well. So what clinical signs might we see with somebody with heart failure? Well, here's a sort of ABC, if you like, of things that you might expect to see. So low blood pressure, high heart rate, you might see engorged neck veins, very narrow pulse pressure. You might see peripheral edema, and they might, if it's very acute, have shortness of breath or wheeze. So thinking about a prolonged refill time or cool peripheries, well, we know that our compensatory mechanisms, our renin-angiotensin, aldosterone and baroreceptor reflex, cause vasoconstriction, and that will cause sort of cool peripheries and prolonged cap refill. We will see a tachycardia, and this will be baroreceptor autonomic mediated. So there will be decrease in frequency of efferent impulses, parasympathetic impulses, which would ordinarily slow down the heart rate. So we see a decrease in those impulses, so the heart rate will go faster. And then if the right side in particular of the heart is failing, or if there's sort of back pressure, if you like, you'll get peripheral edema forming sort of in the legs or anywhere where there's sort of gravity at play. Now, if we think back to our Starling forces, and we've got our capillaries that are sort of semi-permeable, they'll let through some water and some fluid, and our Starling forces are hydrostatic pressure, which is the pressure pushing fluid out of the vessel into the interstitial space, into the tissues themselves, and then the oncotic pressure of the proteins within the blood vessels draw the fluid back in, and so they're ordinarily sort of quite balanced. However, if we get an increase at the venous end of things, so the heart isn't dealing effectively with pumping blood, and so you get sort of back pressure, that means you get sort of greater pressure at the venous end, and so you're still having water being sort of squeezed out. There's still force squeezing out water and fluids all the way along the length of the capillaries. The oncotic pressure doesn't change, and so you've got a net movement of fluid into the tissues away from the blood vessels. And this net fluid movement into the tissues we would see as edema, pulmonary edema, not pulmonary edema, peripheral edema in this instance. And the same thing will occur in the pulmonary vasculature as well. So here's a normal chest x-ray, nice and clear. You can see the lung fields really nice and clear. And this is what pulmonary edema looks like. So you've got a lot of fluid sort of all throughout the sort of bottom half of both of these lung fields. And similar to before, there's increased pressure towards the venous end of those capillaries, and so there's still fluid being forced out into the tissues, and there's not more fluid being sort of returned to the vessels, and so you get fluid collecting in the tissues, and this would be responsible for the wheeze and the fine respiratory crackles that we might find on examination of our patient in acute cardiogenic shock. So that we've highlighted the causes of cardiogenic shock, we've said how these can actually be complicated by compensatory mechanisms, and how we've looked at Starling forces as a means of explaining why we get peripheral and pulmonary edema. Thank you very much.